And we are live, Senators.
Okay, thank you. Good morning, everyone. This is Senate Health and Welfare Committee. It is January 24th, and we are joined first with Nolan Langwell and Amron Abajali to look at issues relating to the insurance system overview. And before we begin, just to let folks who are out on YouTube know, their PowerPoint is not yet posted on our committee webpage. It will be posted. We've been having some technical difficulties, so it will be posted ASAP. In the meantime, you can look at the presentation on the screen as we go through it. So, welcome.
Thank you.
And it's all yours.
Great. Let me do the screen share. Take a second. Cool. All right. Okay. Okay, that's right. It's PDF. All right. For the record, Nolan Langwell, Joint Fiscal Office.
Amron Abajali, Legislative Counsel.
So today we're going to do a very high-level overview of health insurance 101. This might be the final one of the tutorials that I know of, so you'll be finally rid of me on this stuff.
Not necessarily.
On this, well, maybe not necessarily. That's true. There's other stuff, but for now, and we're going to walk you through some high-level, just basic health insurance terms to kind of help familiarize yourself with some of the terminology. We are not experts, nor do we claim to be experts in some of these things. So, well, we're not. We'll let you know. Well, we're not experts on any of it, but anyway. We're going to talk about insurance. We'll start with a high-level overview. We'll talk again about self-insured. We'll talk about some insurance basics like actuarial value, cost sharing, risk pooling, premiums. Talk a little bit about rate review, and if we have time, we'll kind of go briefly into HRAs, HSAs, and FSAs. And I'll unacronym them later.
Thank you.
Yes. So this is a snapshot from the Green Mountain Care Board. This is in their expenditure analysis. I believe I sent this link to Alex. And this kind of gives you a sense of the market when we're talking about insured individuals. And you can see how many people are in the various groups. We have our, this is just meant to be a reference. So you can look at it later on or through the document and you say, how many people? And I can say, check out slide 3, 4. So again, this is a slide that you've seen before. This is just, by the way, cut me off or jump in.
Okay.
Otherwise I'll be.
Can you go full screen with that?
Can you make it full screen with your iPad?
No,
It's
that's
a
You can get it up on your
Zoom,
iPad.
but that's it's a
Yeah.
PDF, so I can't do more than that.
It was just sent to us in an email too.
From Alex, you'll see it, and you can pull it up.
So this is
You can get your email and you can pull it up and then you can see it.
so this is an illustration you've seen before, kind of showing you, like the gray is the insurance market, the private insurance market. The white are the Medicare, Medicaid, and then the uninsured. So we're talking about the gray box today. Previously, we've talked about different color boxes. We think about, many people think about the private insurance market in terms of like employer-based and the individual market. So that's who you get your insurance through. So most people get their insurance through some kind of employer-based insurance. And that breaks out into folks who are self-insured, which I'll get into, which includes the federal employee plan. And then we have two different types of insured. We have what's called the large group, which is always employer-based. And then we have a small group, which is also always employer-based, but they might not be, they're not always large companies. And then we have our individual market. Those are folks who do not have those are folks who do not have employer-sponsored insurance, so they have to go and buy the insurance themselves. And then we'll talk a little bit about qualified health plans and reflective plans, but not too much detail with that because we can go down wormholes very, very easily. Again, about half of Vermonters have private insurance. Most of those are employer-based insurance. Approximately 3/4 of those are, and 3/4 of those are self-insured. So the little chart on the bottom, these are employer-sponsored insurance, and you can see 74% of people who have employer-sponsored insurance are on a self-insured plan. And what do we mean when we talk about self-insured? And we talked about this a little bit a couple weeks ago. Basically, in an you have insured plan, which we talked about, you have your small group and your large group, then you're self-insured. Insured, the insurer bears all the risk. Usually, so it's like it's a normal transaction where an employer decides they want to offer health insurance. They call up the insurance, they go to the insurance company or their broker and they say, I want to buy insurance for my employees. And they buy the insurance for their employees in the regular market. They might pay 80% of the premium or whatever, 50%, whatever. Those insurance products are subject to state regulations. Self-insured, though, might say, well, we're a pretty big company. It's usually large companies, but not always. They say, we think it would be cheaper for us to pay the claims versus pay the premium. And that's why you see a lot of large employers also having wellness programs. My previous employer talked about, my predecessor talked a lot about, we'll get into pooling, but if you have a pool of, if your company employs aerobic instructors versus coal miners, you might say, we have a pretty healthy population, they're young, I don't think that they're going to get really sick. I think it's cheaper. They might say it's cheaper for us. It's an economic decision to pay the claim. And so what they would usually do is they would purchase, they would still go to a company like Blue Cross Blue Shield or others, MVP, whoever, and they can buy a plan which basically is a third-party administrator. So the card would still say Blue Cross Blue Shield or MVP. They're just administering the plan. They're just adjudicating the claims, but they're not taking on the risk. With an insured plan, the insurance company is taking on the risk. With a self-insured plan, the employer is taking on the risk. And self-insured plans are not subject to state regulations. So for instance, several years ago, when we've done mandates on mammograms or colorectal screenings, if you have a chart, the mark, remember the chart that showed the people we regulate? If we do something like that, that small sliver of small group, large group, and individual plans, those have to be, they have to follow the mandate, whereas a self-insured plan would not have to do that mandate if the state passed it. But we find that a lot of self-insured plans usually doing them. So we've been, I think in the past, we did mammograms and colorectal screenings. We found most of those self-insured plans were already doing them or went ahead and said, I think that's a good idea, we'll do it too. We just couldn't make them do it. And that falls under what's called ERISA. We're not going to go into ERISA. I don't even remember what it stands for. Do you remember?
Not offhand.
But it's basically this employment, retirement. It's a federal law that's been on the books for a long time, and it preempts state law, basically.
But Hawaii is exempt from that. Hawaii can regulate ERISA plans.
Yeah, let's not confuse.
We won't confuse.
Yeah,
But
so
for
this
one
is-
state to have it and our state not, it's just inequitable anyway.
Yeah, so you can see we only regulate that small sliver
Yeah.
of. Anything you want to add on self-insured?
I just wanted to, I don't know if you said this explicitly, but when we're talking about bearing the risk, we understand bearing the financial risk. If you're anticipating that claims for a certain group of people at a company are going to be X amount of dollars, and they come in instead, the medical claims come in at say X plus 20%. If you're in an insured plan, it's the insurance company that's going to have to deal with that 20%. And if you are a self-insured plan, the company is the one who's going to have to come up with that 20%. I just wanted to make that in dollar, a little more in dollars.
So we're going to talk about some insurance basics. Do you want to talk about actuarial value or do you want me to?
Oh, gosh, okay, I can take the first stab at it. So actuarial value, and to put this in context, this is a concept that comes from the Affordable Care Act and is only dealt with within the realm of our small group and individual markets within Vermont Health Connect. So this slide is specific to Vermont Health Connect and the plans that are on Vermont Health Connect for small group, fully insured, and individual groups. So you may have seen when you have shopped for insurance maybe previously that you can have your platinum plan, your gold plan, your silver plan, a bronze plan, and each plan comes with a different level of let's say share that the insured person has to cover for the plan. So for example, when you're looking at a platinum plan, right, the plan itself is going to cover 88 to 92% of the costs of that plan. And then the insured, the individual, is going to pay is anticipated to pay the remainder of that value through different types of cost sharing. So that would be sort of out-of-pocket costs like deductibles, co-pays, co-insurance. So each type of plan in the exchange is going to fall into one of these categories: platinum, gold, silver, bronze. And each insurer has to demonstrate that their plans are falling within those categories. And why do we have those categories? One, so that people know roughly what their out-of-pocket costs are going to be within those plans, but also the federal government uses those different tiers to figure out what subsidies are going to be available for certain plans. So what selection an individual makes when deciding on their plan is going to be a combination of both their out-of-pocket costs, but also whether their plan that they're choosing is a plan that allows them to get federal subsidies if they meet the income threshold for those subsidies.
But the higher the actuarial value, the lower the beneficiary potential burden, exposure, financial exposure. So the higher the actuarial value, the lower the exposure, but usually the more expensive the premium. So you're paying for higher actual value because you think that, you know what, you'll have less of an out of pocket. So when you hear, so a lot of times the decisions are often made, you know, you always heard the term young invincibles, and you might find someone who's fresh out of college who has no health history. So you know what, I don't want to pay a lot of premium. I don't think I'm going to get sick. I'm going to pay for a bronze plan. It's a lot cheaper versus someone who has more financial resources or has some health issues. You know what, I think I'm going to get a gold or platinum because I can afford it, and you know I've got diabetes, and I just want to make sure that it's risk. You know, like, so it's a personal decision as well as a financial decision.
Would you guys prefer we wait on questions?
No.
Okay. In a bronze plan, I'm assuming that means you're gonna have a really high deductible, is that correct?
Yeah, it might be high deductible, it might be higher cost sharing, it's usually all of the above.
Okay.
That's why we say out of pocket exposure. There's various, when actuaries go and they run to come up with their plan, they might have a mixture of, they might have 3, you know, silver plans, and you'll see they have different deductibles, but they offset it with different cost sharing. So it's just a formula that we use. But ultimately it's about, you know, overall out-of-pocket risk for the beneficiary.
Got it.
Here's some basic terms that we've talked about, you know, cost sharing. So we've got our deductibles. I think everyone here knows what the deductible is, right? Everyone here, I think, knows what co-insurance is, which basically is, you know, for example, an employer might pay 20% towards the charge for service, and the plan pays 8%. So you have co-insurance as well. Then you have your co-payments. You know, that's like I go to the doctor and I have a $20 copay for an office visit, or a $50 copay for an emergency room visit. And so I'll show you this. This is like a smorgasbord to give you a sense of what a plan might look like. So these are examples of Vermont Health Connect. I think these are both MVP and Blue Cross Blue Shield and their standard plans. And so you can see that the deductible for bronze is 6,400 for an individual, and for gold is 1,400, and for platinum is 425. And you can see there's a medical out of pocket max. So on a bronze plan, you'll pay up to you may pay up to $9,000, whereas with a platinum plan, once you hit $1,500, you're off the hook. You don't have to pay anything. So, and then you can see the different office visits. So this just gives you a sense, but then you can see what the different premiums are for both Blue Cross Blue Shield and NTP. You might even, if I should have done a slide like this, but I could have put 4 different silver plans, and you would see that there's multiple. Like I said, there could be different smorgasbord of formulas. So then one might have a $4,000 deductible, one might have a $5,000 deductible, but have a lower medical out-of-pocket max, or might have higher prescription drug or whatever. So when the actuaries, the insurance companies build these, they think about all these moving pieces of what they're trying to get to in the overall. It's like, what spices are you going to add to the dish?
From a policy perspective, do you remember what we have done? Can you just, or you can fill us in another time, on providing for primary care visits, number of primary care visits without out of pocket, where that has landed?
I don't know.
So, we can look at that. I know VSA has their own insurance coverage, but that's a self-insured. But did we follow through with a policy that allows for 2 or 3 primary care visits a year without copay?
I don't know the answer to that either.
Yeah.
I know that there's stuff around preventive care.
Yes.
Which might still be your primary care, but that's
Might be the
different than
same
what
thing.
you're saying.
Yeah.
Because it might be a follow-up that's not preventive, or I don't know.
I love that all my questions are broadcast out to the universe. But that monthly, so that last line, monthly premium,
Mhm.
I guess I'm a little confused right now. That's premium to,
So that's the cost of the plan. So these are, so if you are,
to the insurer.
yes, like that's the
Okay.
premium. So I
Gotcha.
pay, let's say, or somebody is paying $640 a month to the insurance company to get that. Now, it might be, if this is a small group, the employer might be paying 80% of that, and you're paying 20% of that. If you are an individual plan, let's say and you have subsidy, if you're under 300% of federal poverty level, actually 400. Actually, I won't get into details.
There's a range.
You might be below a certain FPL threshold, and you might be able to get both state and federal subsidies that significantly reduce your premium. But if you're higher income, you probably may not.
Why is platinum so much higher than bronze? I guess I'm confused.
Again, so platinum has a higher actuarial value, so which means that it covers more, and your out-of-pocket exposure is less. So the lower your deductible is $425 for that plan versus a bronze, which is $6,400. So if I get sick, I go to the doctor and I might break my arm, and it's $10,000. My out-of-pocket max, I'm only going to have to pay $1,500 of that to medical out-of-pocket max, versus if I break my arm and I have a bronze plan, it's $10,000. I'll be paying $9,100 before, and my insurer will only pay $900. So I'm paying to reduce my exposure.
Gotcha. Okay, thank you.
There's a lot of stuff on this stuff, and I know that when you first are looking at this, it's confusing, and I've spent a lot of time looking at this, and it took me years to really kind of like all these moving pieces. So you should just understand this stuff is complicated.
No, I know it is. I guess I always figured out with the platinum, you have lower premiums and lower exposure.
You're paying for more. You're
Right.
paying more to reduce your exposure.
Gotcha, okay.
So that's why a lot of like employer plans, they might say, hey, we've got gold plans or platinum plans, we're paying 80%. That could be like, one of the incentives to come work for us because we offer really good medical. A lot of people consider that, especially for a family plan. If I have full family and I'm a platinum plan, I'm paying $3,200 a month. But if my employer is paying 80% of that, that's a really good benefit.
If you go to the office visit lines there for primary care, and because we'll be looking at primary care in here a little bit. And one of the concerns that has been expressed over time is that if there's a high cost, if you have to pay out of pocket for a primary care visit, then people won't go. And then their condition, whatever it is, might get worse. So if you look at the expense for a single primary care visit for bonds, there's a deductible, and then every time you go, you pay $35 and so on.
And just for a reference point, if you're on Medicaid, you have no deductibles, and you have no co-pays except for prescription drugs, which you pay $1, $2, or $3, depending on the situation. And then there's a premium if you're in a certain Dr. Dinosaur program, you might pay as much as $60 a month for all your kids total. So you have one kid, you have 5 kids, it's $60. And then there might be another premium for the farm, and that's it. Other than that, most of Medicaid folks do not have deductibles, co-insurance, co-pays, etc. Or premiums. So risk pooling. So a risk pool is basically a group of individuals whose medical costs are combined. This is, the fundamental concept of how insurance works. The idea that large amount of people pay in, and the healthy folks essentially help pay for the sicker folks. So, for instance, when we talked about you have 2 pools of people, one might be the the aerobics instructors, and one might be coal miners. You're going to imagine that the claims experience in the coal miners are going to be significantly higher than the group of aerobics instructors. Now, that's not a real group, but it's just to give you conceptually. But I don't think you can actually have a group like that. I'm
Coal
just
miners in this state,
no, but it's really more a visual than
yes, it's
actual.
very good.
So it allows higher costs of the less healthy to be offset by the relatively lower cost of the healthy, either in a plan overall or within the premium category. So I might let you do community rating and guaranteed issue.
Sure. So once again, when we're looking back to the Affordable Care Act and we're looking at the plans on the health exchange, there is a concept of community rating. And when each state, back when the Affordable Care Act was enacted, and each state had to decide what they were going to do, whether they're going to have their own state health exchange for insurance, they had to decide how they wanted to do rating for the pools that they have in the exchange. And the federal government did allow states to make some differentiations in how they rated different categories of people. You could have people pooled for community rating based on whether there's a smoker or a non-smoker, right? We know that smokers tend to have higher health care costs over time than non-smokers. Vermont, when it was establishing the Vermont Health Exchange and our plans, decided to do pure community rating. Everyone is in the same pool. So risk is being calculated regardless of whether someone is a smoker or non-smoker, regardless of how old they are, regardless of gender. So it's just, I guess, important to know that community rating is, like pure community rating is what we do in Vermont. And so that you know that there are states that do differentiate between categories. I think some of the most popular are smokers and non-smokers, and then age, by age rating. And then guaranteed issue is just the concept that when a policy is offered, really any eligible applicant can purchase that policy regardless of their health status. So the idea that we're not saying you can't purchase this policy at this price because you have a history of very high healthcare costs. So those are 2 concepts to keep in the back of your mind.
And the general thinking has traditionally been the larger the risk pool, the more stable and predictable the premiums would be. The idea that the more people you have in it, the more diffuse the risk is spread. That said, there's, you, just because you have a large pool doesn't necessarily mean your premiums go down. And one of the issues in Vermont is because we are such a small population, don't have a big risk pool. There are some places that probably have risk pools bigger than our total commercial insured market. So earlier on, the individual and small group markets were merged to try to, because each had about 35,000, to try to figure, if we put them together, it could help bring premiums down. Well, it helps, that gets into the theory of which pool is better and which is not. Currently, those markets are unmerged, but the concept underlying premium previously had been the more people in our pool, the better. But like I said, in Vermont, some would argue, is there a difference between a 35,000 size pool and an 8,000 person pool? And one would argue, hard to know because they're still relatively small in general. So that's been the underlying concept in general thinking. I jumped ahead. So Vermont was one of only 2 states that had merged its individual market. So again, like I said, you have individual market, which is 24,000, and small group, which is 45, but combined they were 70,000. Currently, they're unmerged. I think that they are slated to remerge again in another year or 2, and they were unmerged. And I want to get into there was a scheme called silver loading, and I don't want to get into that. You will at some point, but ultimately, just know that this is something you'll get into. And it was a temporary fix. You'll probably hear about it within the session and have the conversation about whether or not we should merge or remerge, in which case we can come back and kind of do some of the fundamentals of this to remind you again.
Just to add on to that, when we're talking about merging and unmerging, we're talking about which pools of people our premiums are going to be based on. Right? So when the individual and small markets were merged, you're looking at all of those individuals within Vermont Health Connect were part of the same pool of people. So calculating premiums for each of those plans was based on the healthcare costs of both individuals and anyone who is participating in the small group plan. With these 2 markets unmerged, now you will have premiums for the small group market individuals being calculated here based on their experience, and then premiums calculated for the individual market based on their experience, as well as other factors. But so you'll see the trends of medical costs over time are different for small group insurers and individuals, and there are a variety of reasons for that. But so when we say that they're unmerged, it means now that they are choosing from different plans that have different premiums. And as Nolan said, they're temporarily unmerged at the moment. We did not change the statutory laws, but we did in session law say, for purposes of this plan year for 2023, the premiums for these 2 groups are going to be calculated separately. So they are scheduled to, no, it was in response to additional federal subsidies that are only available to certain to individuals, and in order to take, we won't get fully into that today,
It's an
but
easy rabbit hole to go down.
it is,
And
the short answer is we were able to maximize federal subsidy dollars by having them temporarily unmerged. But the federal subsidy dollars were due to expire, so that's why it was temporary.
And so the conversation will be, what are the Fed doing, and then what should we be doing or not doing, and then what should we do or not do in response to that?
Gotcha. This was a really fun conversation this year and the year before.
Yeah.
And it sounds like it will be again this year or next year.
I think in a couple of years.
Yeah, I don't know. I don't know if it's this year or next year.
3-year.
To be after next year, right?
Okay, I don't know.
I think. Anyway,
We'll blink and it'll be here.
Yeah.
And we're not the only state that did this. So. Another fundamental concept to insurance pooling is this concept of adverse selection. And essentially it's when, because you have insurers, they're competing against each other, right? Each insurer has its own pool, right? And so when an insurer or a market as a whole contains a disproportionate share of unhealthy individuals. So example might be when people are allowed to wait until they're sick and need healthcare. So this, again, the idea that the healthy are paying for the unhealthy. we have these open enrollment periods, for instance. You can only enroll into your health plan in a small window. And then you either have insurance for the year or you don't. Insurance usually is on a calendar year, not always, but most of the time. So this idea that people can just enroll whenever they're sick, then they wouldn't buy insurance until they need it. So like, well, I'm not sick, I'm not gonna pay the premium. Like, oh, now I'm sick, I'll go buy my premium. Well, you haven't been paying into the pool. So that's an example of adverse selection. The Affordable Care Act, it also instituted an individual mandate penalty as one measure. Again, that penalty was eliminated, but again, what the idea was they were trying to require insurance. I think Massachusetts may have had a penalty, I don't remember prior. But anyway, there was a lot of conversations in the past to try to force people to buy insurance or to incentivize people, not force, incentivize folks to buy insurance or pay a penalty if they did not pay insurance. Also along this line is there's another thing called the risk adjustment. And again, this was under the Affordable Care Act, the Center for Medicare and Medicaid Services would collect funds from insurers who enrolled more low-cost people or low-cost health people and distribute them to the insurers who enrolled more high-cost people. So we have two insurers, Blue Cross Blue Shield. And if one of them had more of a higher population of sicker folks than the other, well, then the other one will say insurer A versus insurer B. If insurer B somehow had more of the older, sicker folks, for the same product, they'd be able to charge, they have to charge more than the other company. There's an economic disadvantage to that. And so, and then of course it would start to spiral because, well, next year I'm going to buy this and they're going to keep switching and the one would spiral. So there's this idea where one insurer has to pay some money to the other insurer to kind of create this level of equity. And that's only within the Affordable Care Act and with the exchange plans. Did I say that correctly?
Yes.
Okay, this stuff's complicated.
And that's a tiny pool of people in this state compared to everything.
Yeah, and last I checked, one of the insurers was paying the other insurer. I won't say which, I can't remember which or how much, but it does happen.
Yeah, every year there is an adjustment. It's part of so each year after rates are approved by the state, that information is submitted to the federal government. And as part of that rate review process, CMS is going through the claims data from all of the insurers and figuring out which insurer has higher cost claims individuals, and then making a determination from the previous year how that should even out. And again, this is a market stability issue really to keep insurers in the market.
Premiums. When we talked about actuarial value before, a lot of folks would used to ask me, does that include the cost of the premium? And I was like, no, the premium is you buying an actuarial value. So you're buying a product on actuarial value. So people would confuse the premium with cost sharing or other out-of-pocket costs. And I always try to explain it as your premium is like the cost, and the actuarial value essentially is the product that you're paying for, or one of the products you're paying for. So there's a lot of factors that go into how much your premium is. How much time do we have here?
We're good.
Okay. There's a lot of factors that go into how much a premium costs. Your projected medical or pharmaceutical costs for the pool. So what was what they call experience of the pool? The number of people expected to be in the pool, again, the size of the pool is a factor. There's what's called actuaries, and they're the ones who work for the insurance companies and do all the calculating and try to figure out, because really what they're doing is they're trying to look at a crystal ball. And they're saying, how do we set a premium that we know will cover our costs if people are sick? We don't want to charge too much because we want to be competitive, but we don't want to charge enough because we want to make sure that we stay in business. And so they're trying to figure out what the costs of the premium should be when they build these products. So they're looking again, medical and pharmaceutical costs, what's the experiences? What do we think the experience is going to be in the next year? Number of people, okay, there's some people were in the pool this year. How many we're going to lose or how many we're going to gain? They have to predict what they think that pool is. What are the administrative costs to administer the product? And that might include sales, enrollment, claims processing. Claims processing is adjudication. That's a big thing. It's important. Customer service, paying for people who are on the phone that can answer it. Product development, and then contribution to reserves, which is also really important. So we talked about the risk. Insurance companies need to have a reserve so that if they undershoot the value of the premiums and they have more, or there's a pandemic or something that makes their costs higher than they expected, they need to have some level of reserve, just like any other company. Also, like taxes. In Vermont, we have taxes on things. We have what's called we have a claims tax, and insurers pay almost just shy of 1% of their total claims to the state. There's also another insurance tax that all insurers pay, not just health insurance, but auto and others. There's fees that they have to pay when they do their rate filings and other stuff. So there's all kinds of fees and stuff that they have to build into their product, just like any other business overhead costs. What are the laws and regulations? Not just existing laws, but the uncertainty. What is the federal government maybe doing? Is there financial risk to that? Their plan design. So that was that slide where I had the cost sharing and the deductibles and the medical out of pocket. That's what's known as a plan design. And the plan design, what's in and what's out to kind of. And then also competition, like how do I stay competitive in the market? I don't want our premium to be more than my competitors by a significant amount. So there's all those factors they have to go into that kind of help determine how much a premium would be. There's also this idea of medical loss ratio. Do you want to explain it? Do you want me?
I can explain it.
I keep throwing all that. Oh, why don't you explain it? You work for
So the medical loss ratio is the percentage of premium an insurer spends on claims and expenses. The Affordable Care Act requires most insurers that cover individuals and small group businesses to expend at least 80% of their premium income on healthcare claims and quality improvement. So what they're looking at the rest of it is for all of those things that Nolan was just talking about in terms of administering the plan, having people available at the call centers, doing the claims administration, making sure that they're contributing towards their reserves. So you'll have, that must be under federal law, at least 20%. There are, I believe, financial penalties if they fall below that 80%. But in order to sort of protect the idea that the majority of premiums that you're paying in should be going towards the cost of healthcare, of your healthcare, not towards a large company profit or something along those lines.
When we did this presentation in healthcare, Sarah Teachout from Blue Cross Blue Shield was in the room, and someone said, "What's yours?" And I think theirs is pretty high. Blue Cross, I think they were like 93.
I think she said 92 or 93.
So they were high. Which means that most of that is going towards the cost, and that smaller percentage is just the costs. This is a slide that I stole from AHIP, but I thought it kind of was a good visual, kind of giving a sense. And
AHIP, what's that health in there?
It's the Association of Health Insurance Plans. I think they're national. And what I'll say is that this may not necessarily represent the Vermont experience. I think the insurers in Vermont would say, well, we have higher this and higher that and lower this. But I think it's just kind of in general, it just gives you a sense of like what goes into a premium dollar. So I'm not going to go through it, but I threw it in this because I thought it was a useful. And let's get this next slide too. And this was the pie chart I was looking for before we talk about it. We're going to jump into rate review. Because this is an important part of the regulatory piece. This is a piece that you have some say in legislative law and legislation about how we control that small population of who we regulate. So there is this health insurance rate review process. Green Mountain Care Board is primarily the regulator in the state who does this stuff. So an insurer would submit their filings to the Green Mountain Care Board. They often request a rate for a particular health insurance plan. So they won't just say, here's our rate. They'll say, okay, here's our small group. This is our large group. This is this group. This is that group. So they submit many filings. And then there's a public comment period where the public can comment on it. And then there's the opinions. So the Green Mountain Care Board, there's a whole process. The Green Mountain Care Board, within 60 days, they must post the opinion of an actuary discussing the reasonableness of the rate change and the opinion of the Department of Financial and Regulations regarding the impact of the request rate change on solvency. So the Green Mountain Care Board does the majority of the lift in terms of looking at the premium and reasonable, hiring actuaries. Department of Financial Regulation has a small piece, just making sure that and there's a big part around the reserves, making sure that the insurers can remain solvent under the premium structure.
Can I pause for just one moment? I think we didn't include on this slide, but I just wanted to add in so you're aware. In addition, before the rate review process gets started, the other piece that the Department of Financial Regulation does on the front end is to make sure that all of the plans that are being filed meet all federal and state regulations and laws for health insurance plans. So they're going to review the forms of the insurance plans to make sure that those all meet what they need to meet. And so that happens leading up to the rate review process. Once the insurers know or are pretty sure that their forms are correct, then they can proceed with the rates. Sorry.
Oh, please. Then the Green Mountain Care Board would hold a meeting within 30 days. Hearings to be waived, but usually for the exchange plans, there can be all-day affairs. Where you have, the Green Mountain Care Boards at the table, and then the insurance company is at another table walking through their rate proposal. And then you also have the healthcare advocate, Mike Fisher, who is a party in statute, and they'll actually have a table too. And so you've had multiple actuaries look at this and have weighed in and have a conversation about is it too high, is it too low, and the insurance company justifies why they think the premium should be X, or why they put X amount of reserves or whatever. And we should joke around, call it dueling actuaries. And then there's a decision. The Green Mountain Care Board must decide to approve, modify, or reject the rate request within 90 days. And appeals can be made to the Vermont Supreme Court up to 30 days after the decision. So that's the high level overview of how rates are reviewed in Vermont. And what I'll say is Vermont is a pretty rigorous rate review process relative to a lot of other states.
Is this a annual procedure, or is
Yes.
it called when necessary, or?
It's annual.
Annual.
It is annual, and it happens at different times of the year. So you'll always have the individual and small group markets happening in the summer because they need to have the premiums in place in order to make the calculators for the federal subsidies for the plan starting in the fall. But for a large group, fully insured plans, those filings happen sort of throughout the year because not all large groups have their plans start January 1st. Sometimes they're scattered through several quarters of the year. So it's a year-round but annual for each type of plan.
Yeah, that sequence gets to be problematic for insurance companies as well as others. Maybe something to look at.
So the Green Mountain Care Board is tasked with this determining if the rates are excessive, inadequate, or unfairly discriminatory. Some of this is straight from statute, and that's part of their actuarial review. They also have to determine if the rates are affordable, promote quality care, promote access to health. Again, that's in statute, I believe. They have to make sure it protects insurance solvency and is not unjust, unfair, inequitable, misleading, or contrary to state laws. And also must consider other changes to health delivery, payment methods, amounts, contributions to reserves, and other issues at its discretion. The history, to step back for a second, of insurance regulation has changed through the years. Years ago, there used to be a 3-member board called the Healthcare Authority that oversaw health insurance, or this stuff. And also hospitals and some aspects of hospitals. And then it was merged to what's called BISHCA, which is Banking, Insurance, Securities, and
Healthcare Administration. Yeah.
And that existed for many, many years. And they looked at all areas of insurance, not just health insurance, but also hospital and healthcare administration piece. And then Act 48 in 2011 or 12, that was the bill that was to create universal healthcare. Green Mountain Care Board was created to sort of be the entity that was supposed to oversee that system, as well as the insurance rates, the markets, et cetera. And so a lot of the stuff around affordability and quality was added, and payment reform has been added to it through the years, as the Green Mountain Care Board's role has been more than just looking at insurance rates. They try to look at the system as a whole. They also do hospitals, certificate of need, which is large capital investments by hospitals. They are party to the all-payer model. They look at the accountable care organization, other pieces that have been central to Vermont's healthcare reform strategies. So that was a bit of an aside.
History lesson.
Little history lesson, yeah. So when we think about like, well, how did this come to be? How do we decide who regulates what? There's history there.
And there's still tension
course.
around a lot of this.
You don't say.
A little.
I don't know if you've had I think you have had the pre-mountain care board in, correct?
They're coming in Friday.
Oh, okay, so this is a good little primer.
Yeah.
They'll come in and
This
talk
is
about all the things that they do. And then the office, as mentioned, the Office of the Healthcare Advocate has party status during those rate review proceedings. Again, that's by statute.
And the other group that's coming in is VPQHC, so we can look at that quality assessment piece a little bit. Vermont Program for Quality Health Care,
Something like
something like that.
that. I think it's important to talk about HSAs, HRAs, and FSAs. But what I will also say is I'm not an expert on these.
Yeah.
So I really put these in just to kind of point out that over the years, we've seen a huge change in the structure of how businesses and people are buying health insurance product. So for instance, it used to be, I'll talk about the city of Montpelier. I know for a long time, they had a regular health plan with low, a good health plan. I mean, might have been the city of Leagues, city and towns. And they had a good health insurance plan. And then over the years, a lot of these towns have started to move away from low deductible plans to high deductible plans with an HSA or an HRA. And ultimately, the idea behind it is that the exposure, and it was, at least for the city of Montpelier, their employees' exposure was still the same. Their out-of-pocket would still be the same. It's just a different way of paying for it. So instead of just paying the insurance companies a high premium to have a low deductible, they're saving money to say, you know what, we're going to pay a lower premium, have a higher deductible, but then we'll put money into this HSAs and HRAs, and then the employee may use it or may not use it. And that's a way that a lot of companies and cities and towns have thought this is a way to sort of achieve savings, because in that case, if the employee doesn't use that money, the insurance company doesn't get it. It either goes to the employee or we get to claw it back. So for instance, you have our HRA, the Health Reimbursement Arrangement. And so this is an employer-funded account that helps employees pay for their qualified health expenses. So they can't just pay for all health expenses, it has to be within those confines. They're entirely funded and owned by the employer. So instead of paying, we'll say $1,500, we'll say $1,000, we use $2,000 deductible previously. What happened was they said, so instead of it being, myself. Let me just go back. So actually, go to this slide. So this kind of shows the difference between HSA and HRA.
That's great.
So in this case, the employer might put in $500 to each person's account each year. And in HRA, the employer owns that money. In the HSA, the employee owns that money, so they can roll it over and they keep it. So they put it in. And in FSA, the employer owns the account. So the idea behind it was that rather than pay the insurer a higher premium, they can pay a lower premium than they have the HSA, but they can either claw that money back or the employer or roll it over, or the employer can keep it.
So is that HRA, is that like a general fund where depending on, or is it individually based? So is it individual, is the fund accountable to individuals? So there's a specified amount of money for each employee, or is it a general fund where
I can't talk to the schematics of how it's administered. So I'm not, like I said earlier, I'm not an expert on these particular.
Yeah, it's
I wanted
okay.
to put them in because I think they're an important piece, because we've seen a lot of shift in plans from people buying gold plans to
Yeah,
bronze or silver plans, but we don't know who's going to these HSAs, HRs. We have no way of knowing. But generally, an employer will say, okay, each employee is, entitled to up to $500. It won't be like you get 500, you get 250, you get 100.
yeah, that's,
It's the basics. Now, whether that money is put into an actual account or it's held into a giant account where, I couldn't tell you how the schematics of it work. So, but again, like I said, I'm not a huge expert on this, but this has been a factor that has changed the dynamic of the health insurance market. And it's complicated because we don't actually know how many people are in each of these accounts. We can see that, well, there's less people buying gold plans than there used to be. But how many of those people, is it that employers are just pulling back and paying, saying, times are tough, we don't want to pay, we want to reduce their, or is it that we're paying just as much, we're just doing it differently? We don't know the answer to that. So I will end it there unless Amber has anything. I'm trying to stumble over my words again.
it's okay. We understand.
Sometimes you're the bug and sometimes you're the windshield, right? Anything you wanna
I
add?
don't have anything to add.
All right, so we fumbled our way through that one.
The end for now.
Yeah,
We've got lots of questions, I'm sure.
sure.
Any questions around the table? This has been very helpful.
Yeah, meant to be a high level. Again,
Yeah, no.
we're not experts on this stuff, but these are terms and concepts that are gonna come at you. And we want to at least give you some ground floor, like, okay, I understand the basic concept of actuary.
So it's always premiums, out of pocket, copay. So those things come at us very frequently. How much does the premium cost? And then what kind of premium is it? So how much out of pocket do you have to spend when you go in for care, and then copay? So anyway, let's go ahead, Senator.
I just wanted to add to this that it's a really helpful website to look at, is the Vermont Health Connect website. Because this will show you what doctors who are trying to sign up on our exchange would actually see, including for Medicaid and Dr. Dinosaur. And it has like calculators and information about subsidies and financial assistance and a plan comparison tool and lots of, I just think it's a helpful website. I send it to my constituents a lot, but I think it's really good for us to see it and be on it so we know what people are seeing when they're trying to.
I think I've used it before for myself.
Yeah,
exactly.
it's an improvement over the last set of websites.
Yeah,
It's been gradually improving over time.
Exactly.
Yeah.
It's even gotten better in a couple of years I've been looking at it, so.
So Alex, maybe you could post that link to that webpage for us, and remembering how many people, can you do that, Alex? For the.
Yeah, I'm happy to.
Yeah. that'd be
Yeah,
great.
it's info.healthconnect.vermont.gov.
So the only
Info,
thing is that
healthconnect.vermont.gov.
remember, it's a narrow piece of the pie.
The confusing things more, Vermont Health Connect is administered by Department of Vermont Health Access,
Right.
which is Medicaid. But if you buy a plan through exchange, doesn't mean you're on Medicaid. It's just that that's how we've structured it
ACA.
under the administration of.
Okay. Any other questions, comments? Good. All right, let's just take about 5 minutes and we'll come back with